So I'd like to welcome everybody to the 48th annual meeting of the VES. Thanks for joining us in Sun Valley. We were supposed to be here in 2021, but COVID turned that meeting into virtual, so I think there were essentially 12 people from the EC that were, 6 people from the EC that were skiing, and apparently there was great snow. We did get some fresh snow last night, so hopefully the slopes were fun. We want to thank our industry partners for their outstanding support of our society. Without their support, we would not continue to provide the excellent programming that we do. We hope you take every opportunity to visit with as many companies as possible in the exhibit hall, starting at tonight's welcome reception, which is right after this. There will be food there, and then over the next 2 days. For those who are new to our society and our meeting, we invite you to join and get involved. This is the premier society for early career vascular surgeons, and I mean that. Few housekeeping notes. We hope that you're planning to join us for the President's Dinner on Saturday night. There will be no karaoke, but there should be a lot of good, except for Misty, who apparently now has to sing. You can purchase tickets at the registration desk. Space is limited, and tickets will sell out, so please don't wait. If you're looking for discounted lift tickets, you can purchase them on the mountain this year. Just let them know that you're with the VES, and they will give you our discounted rate. Same goes for rental equipment. You should have received a sheet of yellow paper when you checked in. This is the learner's notification form, which has all the information you need for CME credits. Travel days have been a problem, and so we have 2 papers that won't be on this session. They're going to be moved to later. That's going to be number 5 and number 8, and so that will get us out a little bit earlier. So without further ado, we'll start with paper number 1. The use of intravascular ultrasound during peripheral vascular interventions for claudication is not associated with improved outcomes, by Dr. Bose and colleagues from Johns Hopkins. Come on up.
Good afternoon, everyone. Thank you for being here for the first talk of this session. I am Sanuja Bose, currently a postdoctoral research fellow working with vascular at Johns Hopkins and hoping to match into vascular this March. Thank you to the VES for the privilege of the podium to present this research today. These are our disclosures. So intravascular ultrasound has been used for the treatment of coronary artery disease for a few decades now. And over this time, there have been quite a few randomized control trials that have shown that the use of IVUS during percutaneous coronary interventions is resulting in improved outcomes for patients. More recently, there are physicians who've been adopting this technology to treat peripheral arterial disease. However, we do not have the same level of evidence that shows that this improves patient outcomes. To date, there has only been 1 RCT that was performed at a single institution in Australia. They included 150 patients with occlusive femoropopliteal disease. And while they did find that there were a reduced rate of restenosis at 12 months for patients who received IVUS during their procedure, they found that this was only significant in patients who also had a drug-coated balloon used during their procedure. In the US, there have been a few observational retrospective studies, but these have had mixed results. Our group has previously reported on the practice patterns associated with IVUS use in the US. In 2019, we found that there were 1,627 physicians who performed an index femoropopliteal PVI to treat either claudication or CLTI. As you can see in this distribution of IVUS use rates during that year, the far majority of physicians at that time used IVUS in 0% of these FemPop PVI cases. In that study, we also find that there was a significant association of IVUS use with claudication, with atherectomy, and the ASC OBL setting. We also found that it was actually not vascular surgeons who use IVUS most of all, but cardiologists and radiologists. So this brings us to our present study, in which we aim to evaluate the changes in IVUS use over time and the association of IVUS use with long-term outcomes among patients who are undergoing PVI for claudication. So we conducted a retrospective longitudinal study using 100% of the Medicare fee-for-service claims. we included all patients who underwent an index or first-time femoropopliteal PVI for claudication between January 2018 and December of 2022. We excluded all patients who had any prior diagnosis of CLTI, acute limb ischemia, or any prior PVI. Our primary exposure was the use of IVUS during that index procedure, and our primary outcomes were conversion to CLTI and repeat FEMPOP PVI. We used linear regression and Cox proportional hazards models to evaluate the IVUS use over time and association with outcomes, respectively. So altogether, we captured 69,092 Medicare beneficiaries who underwent an index femoropopliteal procedure to treat claudication. Of these patients, there were 22% who had an IVUS used during their procedure. So we just looked at this distribution of IVUS use rates in 2019, and this is our current 4-year study period where we limited the population to patients with only claudication, but we had as many as 2,530 physicians during this time who performed an index FEMPOP procedure to treat claudication. And you can see that there has been a clear shift from the majority being at 0% to increasing rates of IVUS use. We looked at the baseline characteristics of patients who received IVUS during their procedure versus those who did not, and we found particularly interesting differences in patients based on race and ethnicity, as well as population density of residents, smoking history, and census region of residents. In addition to that, we also found that there were significantly more patients who underwent IVUS if they also received an atherectomy, a concomitant tibial PVI, or were treated in the ASC or OBL setting relative to hospitals. When we looked at the temporal trends during the study period, we found that in 2018, there were about 15% of IVUS cases over the total PVI performed, and this nearly doubled by 2022. We stratified by procedure type and found that there was a significant increase for all procedure types, but there was the greatest rate of increase for patients who also received an atherectomy. When we stratified by site of service, we found that this doubling of the rate also occurred even in the hospital setting. But if we look at the ASC OBL setting, you can see that by 2022, the rate was nearly 50% of all FEMPOP PVI cases to treat claudication involved the use of IVUS. So when we looked at long-term outcomes, over a median follow-up time of 2.7 years, we found that about 22.6% of patients were diagnosed with conversion to CLTI in the follow-up period, and we found that as many as 42% underwent a repeat PVI. Our Kaplan-Meier curve showed that there was a significantly greater cumulative incidence of conversion to CLTI for patients who received an IVUS during their index procedure relative to those who did not. And we also found that there was a significantly greater cumulative incidence for patients who received IVUS versus no IVUS when we looked at repeat PVI as the outcome. In our Cox models, we adjusted for all the baseline characteristics that are at the bottom of the slide, and we found that in the overall population, IVUS use was associated with a greater risk of conversion to CLTI. We then looked at a few different subgroups, including by procedure type. So for all the patients who received an atherectomy during their procedure, we compared patients who received atherectomy with IVUS versus those who did not, adjusted for all those characteristics, and found that there was a greater risk of conversion to CLTI for patients who had an IVUS during their procedure relative to those who did not. When we looked at subgroups who received just an angioplasty and just stenting, we did not see that same relationship. We also looked at subgroups by site of service, and we found that there was, again, in patients who were just treated in the ASC OBL setting, there was a significantly greater risk of conversion to CLTI for patients who received an IVUS during their procedure versus those who did not, a relationship that was not seen for patients who were treated in the hospital. We also looked at our other outcome of repeat PVI and found that in the overall population, there was again an association seen with the use of IVUS and a greater risk of repeat PVI, but in our subgroups, the association was seen in only patients who also received a stent. Now, there's certainly limitations to this study. It is the classic limitations of it being a retrospective analysis and also relying on administrative claims data. But most of all, we recognize that IVUS use in the OR, it allows for 3D visualization that can help in situations where the anatomy is more complex, more severe disease. But the reality is that we can't account for this using Medicare data, but we do know that there's still no association with improved outcomes even when IVUS is being used. So altogether, this results of our studies show that the use of IVUS for the treatment of claudication has continued to increase over time, but there's still no clear relationship between IVUS use and improved patient outcomes. We think at this point, considering the high prevalence of IVUS use, we think that a large-scale RCT to evaluate the long-term impact of IVUS use for the treatment of claudication is warranted. I'd like to thank my whole team who worked on this project, particularly Chen Dun, who helps with our Medicare analyses, and my mentor, Dr. Caitlin Hicks, without whom none of this research would be possible. And of course, again, the best, thank you for the privilege of being able to present here. If you have any questions, feel free to email me, but also happy to take questions right now. Thank you all.
All right, Misty.
You did a great job with your
you.
talk. What do you want me to do with this information? So when I come to a meeting, I look at a talk and I try to see how I'm going to change my practice and what I'm going to do. So what do you want me to do based on this talk in my practice? How do you want us to change our practice based on this?
So that is always important to connect our research back to what we're doing in practice. And in this study in particular, we think the main thing is that it would be appropriate and is about time that we tried to start a multi-center randomized control trial. We know that new technology is exciting and that there are advantages in the OR of being able to visualize, but we're concerned about increasing uses without knowing that there's actually improvement in outcomes. So we think that promoting, starting this randomized control trial would be helpful in finding out if there actually is improvement or if there isn't. And that would be the most compelling way to be able to know what to do in practice moving forward.
Hey, Ravi, Rajani, great presentation, and congratulations to you and your mentors, as always, for continuing to push some of these really important concepts forward. I think, obviously, when we're using administrative databases, we always want to think about granularity of the data. And I appreciate the message and I agree with it, but to play a little bit of devil's advocate, I think we want to be a little careful about the statement as a whole, because I think it still doesn't differentiate bailout IVUS versus IVUS that you planned on doing before the case started, right? Stent goes down in the middle of the case. We know that patient's going to have a bad outcome. Maybe IVUS helps you find the endpoint that's a little more disease than what you see angiographically, and maybe it contributes. And so how do you use your data set to maybe answer that question? So one of the things I would suggest for the manuscript is you have a pretty clear definition of physicians within your data set who use IVUS 90+% of the time versus those who use it selectively, and maybe differentiating selective use of IVUS versus routine use of IVUS helps you get to the message that you're really getting at a little better. But great job.
Kind of want to piggyback on the last sort of question and comment. You know, IVUS in general is a diagnostic modality, not a therapeutic modality. So I question it lumping together with all these other interventions. It seems like you're implying that IVUS is kind of a surrogate marker for atherectomy, maybe other interventions, rather than IVUS as a standalone diagnostic tool doesn't help. You know, there's a number of other, clinical or patient-level sort of trials and results that show that in the setting of femoral popliteal CTOs, that a true luminal crossing with the aid of IVUS has been very beneficial, and patency rates at the patient level, 2 years, 3 years, better. So I would really be careful with this particular presentation, this data set.
Hey, Nitin Singh. Really nice presentation. I think one of the things that you benefit from is if you own in on the femoral popliteal interventions alone versus, and I get people are doing tibial interventions for claudication. I think we all know that's kind of ridiculous. But IVUS is a tool, and many years ago there used to be studies talking about patients who underwent a completion arteriogram after a bypass had worse outcomes. Was it because people were doing it because it was, more complex anatomy and they wanted to make sure everything's okay? So I would just be careful, as stated, about using IVUS as a surrogate for. I mean, if somebody's using it as an indication to show that their work looks okay at the end, I think that's okay. But maybe hone in on femoral popliteal for claudication and see what the results are with that alone.
And along those lines, if we medically manage claudicants, right, very few turn on to become critical limb ischemia. You get a 22% conversion to critical limb ischemia. One could argue that maybe just doing angiography, if we're just going to look at diagnostic studies, is a surrogate for worsening outcomes, and maybe we should treat medically. So I think you have to. It's fun to say, well, IVUS is bad, but I think we really have to hone in to see maybe it's our decision making, but maybe it is that these were the more difficult patients. So I do think you need to compare those rare users versus the all everyday users. Thank you.
Thanks very much.